You know, when you see someone with a severe burn, the first thing you probably think about is the skin, right? The visible damage. But here's the thing. The most immediate, life-threatening danger, it isn't the burn itself. It's actually a silent, internal crisis that kicks off this frantic race against the clock. And if we're going to understand how to save a life, we have to understand this crisis first.
So what is this hidden danger? I mean, if it's not the wound we can see, what could possibly be more lethal in those first critical hours? The answer is a catastrophic internal event.
And really, you can think of this problem as the Great Leak. See, a severe burn sends this shock wave through the body, and it causes the tiniest blood vessels, the capillaries, to suddenly become, well, porous. They just start leaking massive amounts of fluid right out of the bloodstream and into all the surrounding tissues.
This whole phenomenon has a name, burn shock, and it's exactly what it sounds like. With all that fluid just pouring out of this circulatory system, the blood volume just plummets. When that happens, blood pressure drops, and pretty soon the organs are being starved of the oxygen they desperately need to survive. It is a direct path to multiple organ failure, and stopping it, that's priority number one, period.
Okay, so how do medical teams fight back against this? The very first step is to figure out just how much fluid has been lost, and, more importantly, how much needs to be put back in. It is a super high-stakes calculation that has to be done, like, yesterday. To get this number, clinicians often turn to these classic formulas, like the Evans or the Parkland formula. Think of them as medical calculators. They take the patient's weight and the percentage of their total body surface area, or TBSA, that's been burned, and they spit out an estimate of the fluid needed over the first 24 hours.
But, and this is absolutely the critical part, these formulas are not set in stone, not even close. They're just a starting point, right? An educated guess to get the ball rolling. The real treatment? That requires constant adjustment and a whole lot of clinical expertise.
And that leads us away from the question of how much fluid and into what might be an even more important one. What kind of fluid should we be using to refill the system? This, right here, is a core debate in burn care.
So, you've got your number, you know the total volume you need, but what exactly are you putting into that IV bag? What are you actually pumping into the patient's veins? Is it just simple salt water, or is it something way more complex? The choice you make here is absolutely crucial.
All right, so the two main options on the table are crystalloids, think saline solution, and colloids, like plasma. And this presents a really critical trade-off. Crystalloids are simple, sure, but you need massive volumes of them, and they're pretty slow to work. Colloids, on the other hand, are much more efficient at quickly restoring blood volume, which is exactly what you need when a patient's volume is dangerously low.
But wait, not all colloids are created equal. You might think, hey, what about albumin? It's a protein that's already in our blood, so it should be a great choice, right? Nope, it's actually a terrible choice here. Think of it like this. You're trying to fill a leaky garden hose. Because albumin has these tiny little molecules, it just slips right through those damaged capillaries, and worse, it pulls water out with it, making the swelling and the fluid loss even worse than before.
So, yeah, albumin is off the table. Instead, clinicians turn to other colloids. The preferred options here are things like freshly frozen plasma or dextran 40. These have much larger molecules that are way better at actually staying inside the blood vessels to do their job, which is restoring that precious volume.
Okay, so we've talked about how much and what kind, but there's another piece to this puzzle. It's not just about what you give, it's also about when you give it. The entire resuscitation is meticulously planned out over one critical 24-hour period.
And this plan? It's aggressive, and it's totally front-loaded. Get this, half of the entire 24-hour fluid volume is given in the first 8 hours after the injury. The rest is then split over the next 16 hours. I mean, that just shows you the incredible urgency of the situation, right? You have to hit the problem hard and fast, right from the very start.
But you know, as central as this fluid resuscitation is, it doesn't happen in a vacuum. It's happening alongside a whole cocktail of other treatments that are all working together.
And this supporting cast is huge. We're talking everything from powerful painkillers and corticosteroids to heparin for preventing blood clots, and even high-dose vitamin C. It's a really complex, multi-pronged attack to try and stabilize every single system in the body all at once.
So, let's put all these pieces together. We've got the formulas, we've got the fluid choices, and we've got the timeline. But how does a doctor actually use all these tools in the chaos of a real emergency?
Well, a lot of times you'll begin with a pretty balanced approach. A common starting point is a 1-to-1-to-1 ratio of colloids, crystalloids, and dextrose.
But, and you've heard me say this before, this is just the starting point. The real art of it is in the adjustment.
So how do they know when and how to make those adjustments? They rely on real-time data. And probably the most important metric they're watching is something called CVP, or central venous pressure. Honestly, the best way to think of it is as a fuel gauge for the circulatory system. It tells the doctor exactly how much fluid is returning to the heart. It's the key signal that tells them if what they're doing is actually working.
And this CVP reading creates this just beautifully simple and effective feedback loop. The doctors are constantly monitoring the CVP and the patient's urine output. So if the CVP is low, that tells them the tank is still empty. They need to give colloids to boost that volume up quickly. If the CVP is looking normal, they can switch over to crystalloids just to maintain hydration. It's a constant dance.
So, the crucial point here, and if you take away one thing from all of this, let it be this, is that the treatment is never just about the formula. It's all about constant monitoring and correction, tailoring every single decision to the unique response of that one individual patient lying in the bed.
And that really leaves us with a fascinating final thought, doesn't it? We start this whole process with the cold, hard science of formulas and calculations. But in the end, the ultimate success depends on a doctor's ability to adapt, to observe, and to react in the moment. It really makes you wonder, in this desperate race to save a life from burn shock, where does the science end and the true art of medicine begin?